Hello, I'm Dr. Bethany Samuelson Bannow. I am the deputy editor of ASH Clinical News, and we are here with our on-location coverage of ASH 2024. I'm joined today by Dr. Anne de Vaan to talk about her very exciting study called the PRIDE study. So I'd just like to start off by asking you, what was the inspiration for doing this study? What gave you the brilliant idea?
So the idea came because we had a few older cohorts in the Netherlands of women with an inherited bleeding disorder, so hemophilia carriers and women with von Willebrand's disease. And throughout those cohorts, we saw that the incidence of severe postpartum hemorrhage, so more than 1,000 milliliters, was increasing throughout the time and also getting higher compared to the general population. So internationally, we treat hemophilia carriers or women with von Willebrand's disease who are pregnant based on their third trimester clotting factor levels. So internationally, it's 50%, the third trimester cutoff levels. And due to that increase of severe postpartum hemorrhage, we decided in the Netherlands to increase that cutoff level to 80%. And with the PRIDE study, we are investigating if that increase of third trimester cutoff level did decrease the severe postpartum hemorrhage incidence in the Netherlands.
So it's almost like a nationwide QI study, which is so fascinating. Can you tell us a little bit, just kind of a brief overview of what the study design was and then your key findings?
So what we did, the study is in all hemophilia treatment centers across the Netherlands. So if a woman with von Willebrand's disease or hemophilia carrier visited the hemophilia treatment center, we ask for consent to perform in the study. And in the third trimester, we did blood sampling, just as normal standard of care. And based on that third trimester level, if they were below 80%, they would receive prophylaxis during childbirth. And if they were above 80%, they would proceed normally and receive it on demand in case of excessive flooding. And at the end, after childbirth, we measured postpartum blood loss. And we also gave them questionnaires at week 1 and week 6 postpartum to measure quality of life and childbirth satisfaction.
In this change of policy and in the Netherlands, in addition to changing the target at which you started therapy, so 80 versus 50, I noticed that the target goal of factor level was also increased to 150%. Can you tell us a little bit about why that represents an improvement over prior approaches?
Yeah, so if you compare women with an inherited bleeding disorder to the general population, you can see that throughout pregnancy in the general population, clotting factor 8 and von Willebrand factor activity steadily increases with peak levels around 200 to 250% at childbirth. And then you have a steady decrease in the postpartum period. However, in hemophilia carriers or women with von Willebrand's disease, that increase is much less throughout pregnancy, and they receive peak target levels around 100 and 150%. So with the increase of the peak levels, we aimed to make it comparable to the general population. But we didn't strive for 200 due to an increased risk of thrombosis.
Yeah.
So there's a consensus to put it at 150.
Yeah, it's always a careful balance between bleeding and clotting. And can you talk us a little through your kind of high-level results, like your rates of severe postpartum hemorrhage and sort of general postpartum hemorrhage?
Yeah, so in the study we subdivided postpartum hemorrhage into 2 parts. So we had mild postpartum hemorrhage or PPH, which is more than 500 milliliters in the first 24 hours, and severe postpartum hemorrhage, which is more than 1,000 milliliters. In the general population, we only have the numbers of severe postpartum hemorrhage. And what we saw in both the hemophilia carriers and in the women with von Willebrand's disease, because we did those analyses separately, we saw that the severe postpartum hemorrhage incidence was around 12.5% in hemophilia carriers and around 90 to 17% in the women with von Willebrand's disease. While we are still comparing that to the general population because we are getting the data right now, but in the general population it is around 7.8%. So it's still significantly higher, even though we give clotting factor prophylaxis much earlier.
So do you think the current guidelines represent an improvement or still a lot more work to do?
I think there's still a lot more work to do. I can't can't say what the committee is going to do with the guideline because that's a collaboration between the gynecologist and the hematologist. And we're still figuring out what happens to the general Dutch population on the gynecology field. So we're still trying to figure that out. And if we have those data, then the committee can decide what they are going to do with the guideline. The good thing is that if we want, because we did analysis on the current cohort right now, who did receive prophylaxis, so those below 80% and above 80%, so who did not have an indication prophylaxis, you see that the severe postpartum hemorrhage incidences and the mild postpartum hemorrhage incidences are the same. So the prophylaxis seems to work, even though we don't know what would have happened if we didn't give them prophylaxis. But because the rates are the same, the prophylaxis is working.
Yeah. So better than nothing, but not as good as not having a bleeding disorder.
Yeah.
So what do you do in your own practice? Have you changed anything in your practice as a result of these data?
To be fair, I'm not a hematologist, so me personally not. But at the clinic where I'm working at, we're still continuing with the current guideline. So below 80, they receive it, and above, they don't.
Okay. So in an ideal world, your next study, if you were going to change both your threshold at which you administer prophylaxis and your target peak, what numbers would you pick?
Oh, that's a good question, because even though you have the risk of thrombosis, when we looked at our cohort, so both the women with von Willebrand's disease and the hemophilia carriers, we did not find any thrombotic events, except for one severe type with von Willebrand's disease, type 3. But that was due to another complication, so not because of the clotting factors. So I think you can increase the peak target levels higher. So maybe we should aim for around 200%. And then, of course, evaluate how it went with the thrombotic risk. But I don't know if increasing the third trimester cutoff would work, because there are other studies who have investigated 100%. Retrospectively, but they didn't find a decrease in severe postpartum hemorrhage incidents. So I think you also should look at the women in front of you. Did they had a prior PPH? Are they grand multiparities, or is it a consecutive pregnancy? And then decide based on them if they need prophylaxis, if they are at borderline levels in the third trimester. But for the women below 50%, you should give it.
Yeah. And what do you see the role of tranexamic acid in this? I know it wasn't mentioned in the abstract, so I'm curious how you approached that.
What we do for the women with von Willebrand's disease, they will receive tranexamic acid postpartum either way, so not based on the third trimester levels. So we give 1,000 milligrams intravenously right after clamping of the umbilical cord, and then we proceed it 3 times a day orally. 1,000 milligrams for at least 7 days, or until the flooding is gone. So all the women in the von Willebrand cohort received it, up to 99%, so that's good.
Great.
For the hemophilia carriers, it's a bit different. They will receive tranexamic acid if their third trimester levels are below 80%. Or we advise the gynecologist to consider it if the baseline factor 8 or factor 9 levels are below 50%. So in that cohort, we saw that tranexamic acid administration was less. So perhaps it is good for the hemophilia carriers to administer it despite of their third trimester levels.
Yeah. And it's really challenging too with the discrepancy between bleeding phenotype and actual levels. And how would you recommend that people incorporate that into their decision making? You mentioned already, great point, somebody who's had a past history of postpartum hemorrhage. But should we be looking even more at the history, do you think? And is there a potential for doing studies where we divide folks by their bleeding history rather than by their factor number? And is that something you see happening in the future?
Yeah, we collected data on the ICH bed scores in the hemophilia carriers and in the women with von Willebrand's disease. One of the limitations of the study was that the ICH bed scores are usually collected once if a woman visited the clinic, and it's not updated throughout life. But what we saw was that even though they had a severe bleeding phenotype based on the ICH bed cutoff, it did not influence postpartum hemorrhage incidence.
Interesting.
Yeah, but the thing is, I think you need to update the ICH-BET score if they had their first pregnancy, because if they have a postpartum hemorrhage after we took their ICH-BET score, and then you will get additional points.
Yes.
And that's something that's not really happening right now.
That's such an important point, and that is an important limitation of the ISTH-BAT score, of course, is that it only accounts for the challenges that somebody has already experienced, and if they haven't experienced them when they get the measurement. So that is so important. And is that a change that you're seeing be made clinically in your group, or is that something that you're still working to encourage?
We're still working to encourage that, although I think that in our group, so in Utrecht, we are doing it because we're more aware of that, but it's something that we want to give to all the other clinics to think about the ICH-BET and improve it and retake it after a few years.
It's wonderful. It's such important work. Thank you for doing it, and thank you for joining us
and thank you for asking.
On our ASH Clinical News on Location. And thank you, our viewers, for joining us as well for our on-location coverage of ASH 2024. There will be plenty more wonderful and interesting interviews and information in the pages of ASH Clinical News as well as on our website. So thank you very much.